everybody can see the full screen here. We've got kind of a packed day today. So as I said, welcome. We're today going to talk about lecanemab, and we're going to open it up. We hope that there's a lot of conversation around this, newly approved treatment for Alzheimer's disease. The approval, as everyone knows, was an accelerated approval through the FDA on the 6th of January. And then we're very fortunate to have a case by Elizabeth Horton from palliative care. So reminders, please, if you're with a group, enter your names in the chat, mute when you're not speaking. As I said earlier, we love to see your faces, though understand if you're driving or if it's just not the time to do that. We respect that as well. So whatever you're most comfortable with, and know that we love to see your faces. These are some other programs. The University of Washington has a variety of Project Echoes ongoing, as you see, in traumatic brain injury through behavioral health, psychiatry and addiction, and other services. Also pain management. There are other case conferences. So much rich information that you could access through other Project Echoes through the University of Washington. So in any case presentation and any didactic, we take very seriously HIPAA, and we protect private health information. So there's no display of any information that could reveal anything about the person or their beloved. Reminders that all sessions are recorded. So if you have to jump off for whatever reason, or you want to watch it again, it's all available to you anytime on our website. And then please do complete the 1-minute survey, because it helps us, as it really does help us to reflect and to improve and iterate to make this better and more meaningful and impactful, we hope. So here's our updated list of upcoming talks. As you see, Dr. Brock Gaster is going to be talking to us about cognition and aging as our next talk, and so on. Lots of exciting and interesting talks. If you're interested, there's a conference coming up through Providence Swedish, an update on neurology. It's a broader update in neurology, and it's March 3rd, and we can pop that in the chat. And then, as always, an invitation, please bring your cases forward. There's an opportunity to learn, and not just for the community, but also for you in the reflection, we're preparing the case, thinking more deeply about the case. And if there's any way we can help out with that, we're happy to. Please reach out to myself or Chris or Allison. Do expect via email, or you already should have received, an end of year survey, and we want the feedback. We want the 1-minute feedback, and then we want the end of year survey feedback. And of course, it's a vital component for you to receive your CME, this end of year survey. So please do complete that. And thanks in advance. We need it by the 31st. And I think Allison just popped in the chat the link as well. So we have CME through the University of Washington, as you see. We do have a disclosure for today. Dr. Kimmy Demoto-Riley is presently serving as principal investigator for the aducanumab trial, and also serving on the AHEAD trial. And all relevant financial relationships have been mitigated. Dr. Demoto-Riley, is there anything you'd like to add at this point?
No, just want to make sure that these disclosures are here. I am not personally receiving money. It's through the University of Washington, but I am serving as PI. And then there is a supplement to improve the diversity of people coming into the AHEAD trial, which is using lecanemab.
Thank you for your clarification. We have also CNE as well. So here's our hub team. As you see, our smiles and our names, and we represent a wide swath of Washington. We want to continue to grow, and we know that we grow through grassroots efforts as well. So please do, if you see value, spread the word to your colleagues to address this public health crisis of dementia, to really build and scale this care broadly throughout the state. So here we go. So we're going to talk today about lecanemab, which, as people know, is a monoclonal antibody that was approved on the 6th of January, as I said, for the treatment of Alzheimer's disease. So I thought I would do like a really quick sort of intro, I'm going to show a brief video summarizing the New England Journal article, and then we're going to open it up for discussion, okay? So, context, big context. So dementia, the rule in dementia is mixed dementia. It is not the exception. And as you see in late onset dementia in particular, 100% of these who had autopsy had 3 pathologies. And what's very important to note here is that as you see, there was a very high incidence in these of cerebral amyloid angiopathy, which, let me remind you, is a disorder where you have little microhemorrhages and an increased risk for large parenchymal hemorrhages, big bleeds in the brain. So cerebral amyloid angiopathy was seen in many people with mixed dementia in a large autopsy study published in Brain in 2021. All right. We also know that in Alzheimer's disease, frequently it's mixed with cerebrovascular disease or vascular dementia. And in particular, this is even greater in our community samples, meaning in folks who are cared for in primary care rather than these tertiary or quaternary specialty clinics, okay? So in greater than 50% of community samples, there was mixed dementia with Alzheimer's disease and vascular dementia, lots of paraventricular wet matter disease. So how do we identify, and what's the biomarker signature for Alzheimer's disease? The biomarker signature for Alzheimer's disease is this starburst appearing amyloid plaque and this tau protein. These are aggregates that accumulate in the brain. And how do we identify those? We identify those 2 ways. One is through a lumbar puncture with CSF biomarker analysis, and 2 is with amyloid or tau PET imaging. Okay, so when we do the lumbar puncture, which is the CSF analysis, we look at cerebrospinal fluid via lumbar puncture. We look at a ratio of phosphorylated tau to amyloid beta 42. And frequently, this is when this is high, this is consistent with Alzheimer's disease. We also measure total tau. So we measure amyloid beta 42, the protein aggregate that accumulates in the brain with Alzheimer's disease, and total and phosphorylated tau. So let's imagine this gentleman who's got some cognitive issues. So he undergoes biomarker testing. Biomarker testing with lumbar puncture in the cerebrospinal fluid is paid for by Medicare for clinical diagnosis. Amyloid and tau PET imaging is not covered by Medicare. It's used for research purposes to identify folks who have the signature or have the, Alzheimer's biomarker diagnosis, but it is not covered by Medicare presently. Okay. Positive biomarkers does not mean dementia. So you can have the signature for Alzheimer's disease and still clinically not have dementia. And there can be this difference between biomarker and clinical symptoms. Oops, sorry. So in terms of imaging, as I said, there are these ligands, amyloid and tau ligands, which bind to the aggregated forms of the amyloid and the tau in the brain, and they make up the plaques and the tangles we've been talking about. So I'll just show you super briefly that this is an amyloid positron emission tomography scan. And as you see here, on the right, you don't see much uptake in the cortex of this. It's a negative scan. So you see a little bit of uptake in the white matter, but nothing along the cortical mantle. Whereas here you see lots and lots of uptake in the gray matter in multiple cortical regions. So this would be called a positive amyloid PET scan. Again, this is not something we can use in clinical diagnosis. So this is kind of molecular imaging. As I said, it's not reimbursed. It's the sensitivity for amyloid PET is, as you see here, between 89 and 98%, depending upon your study. And then the specificity here is this range. Tau tends to be quite sensitive and specific as well. And as you may note here, when you look at, this is a fulleredeoxyglucose positron emission tomography, that measures metabolism in the brain. It's more sensitive than the structural imaging of an MRI. Here on the right, on the left, you see an MRI of the brain. And you can see here, for example, that there's quite a lot of volume loss in temporoparietal regions, which is you see as well in the FDG PET scan. The amyloid, however, in terms of the uptake is really diffuse, right? Whereas tau tends to, and we'll talk about this in a little more depth, really kind of mirror that and also mirrors the clinical presentation. So what if you have a negative CSF profile or negative amyloid PET? That would argue against the pathological changes consistent with Alzheimer's disease. So somebody might have dementia, but they could have a negative CSF profile or negative amyloid PET, That would go against the pathological diagnosis of AD. They still could have dementia, of course. They could have vascular dementia, many other dementias. Okay, what if it's a negative tau PET, but a positive amyloid? That could indicate the early underlying pathology, because we know, and people have seen these graphs throughout our community of learners over many, many talks, that the changes with regard to amyloid accumulate far earlier than those tau changes. Okay, so, and then as I demonstrated in that previous slide, there's a very strong correlation between the tau distribution and the clinical presentation of folks with, their symptoms. So then this is the New York Times, headline in May of 2022 that there was this CSF biomarker called Lumipulse, which was 97% accurate when they compared to a gold standard of amyloid PET. And this is a ratio of amyloid beta 42 to 40. And so that is also approved for adults who are being evaluated for Alzheimer's and all other causes. So that was approved last year. Now, this is very important, I think. So we don't have plasma biomarkers are not currently approved for the diagnosis or the confirmation of the diagnosis of Alzheimer's disease or any dementia for that matter. Okay, and the use of these plasma biomarkers, is going to be promising because it's lower cost, it's less invasive, there can be more availability. But, and this is very, 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 very important, that there are factors such as ethno-racial effects that need to be considered in it. We haven't done enough studies. So we really have to treat the person, not the test. And this was a recent article that came out in Frontiers of Neurology in 2022. And there was a significant, it's called the Health and Aging Brain Study, Health Disparities Study. It's an ongoing study. And there were differences based on ethno-racial factors. So we're not there yet. Okay. So with regard to treatment, we know that we can use our cholinesterase inhibitors and our memantine. We don't need to have biomarker confirmation of underlying AD in order to use those medicines. Those have been FDA approved for some time. We've talked about their side effects, when to initiate them, and so forth. So that's beyond the scope of this discussion. But to point out that, however, the monoclonal antibodies that are directed towards amyloid do require that we confirm that there's underlying amyloid pathology, of course. So people may remember that aducanumab or Aduhelm was approved with a lot of fiery debate and controversy. And of course, we know we need safe, effective treatments that are equitable and affordable. I just really want to invite our community to acknowledge and reflect on the fact that there remains in America and maybe one other country in the world direct-to-consumer advertising, and we spend a lot of money, pharmaceuticals, on lobbying and marketing, more money than on research, and that this is really continuing to increase substantially. So we need to think about this and advocate and partner with, our different geriatric associations and professional associations around this, because really that marketing can, that direct-to-consumer marketing can really be very confusing, and the regulatory oversight is limited. Okay. So now lecanemab. So lecanemab was approved. I'm going to, rather than going into this very in detail, which I will in a moment, I'm going to actually, hold on one second, escape this. Let me stop the share for 1 second. And let me escape this, minimize this, go back to share, come over here. I'm going to just show this clip. It's less than 2 minutes because I think it does a better job than I might.
Some evidence suggests that amyloid removal slows disease progression in Alzheimer's disease. In a phase 2b trial, the monoclonal antibody lecanemab, which binds with soluble amyloid beta protofibrils, was associated with clearance of amyloid in patients with early Alzheimer's disease. In this phase 3 multicenter double-blind randomized placebo-controlled trial, 1,795 adults 50 to 90 years of age with early Alzheimer's disease were assigned to receive intravenous lecanemab at a dose of 10 milligrams per kilogram every 2 weeks, or placebo. The primary efficacy endpoint was the change from baseline in the score on the clinical dementia rating sum of boxes, a validated measure of cognition and function in Alzheimer's disease, assessing 6 domains that patients and caregivers identify as important. At 18 months, mean scores on this measure were higher than baseline, indicating increased impairment in both groups. The mean change in the score was smaller in the lecanemab group, indicating less cognitive and functional decline. Secondary endpoints, including scores on other Alzheimer's disease rating scales, also suggested less disease progression in the lecanemab group. The most common adverse events in the lecanemab group included infusion-related reactions and amyloid-related imaging abnormalities. The authors conclude that in adults with early Alzheimer's disease, lecanemab was associated with less disease progression than placebo over 18 months. Full trial results are available at NEJ.
Okay, so now let me go back to see where we were here. Okay, so you now see this accelerated approval, my slide, yes? Can everybody see my slide? No? Okay, one second. Let me stop the share and pull it up again because I can see it here, but it's weird that you can't see it. Okay, so let me go back. Thank you for your patience. Now you can, right? Yes. Okay, so I'm not going to read this, but it's a summary slide of the findings of the article in the New England Journal. And as you see, the incidence for, so ARIA is the amyloid-related imaging abnormality that is associated with the infusion with the treatment with lecanemab. And there's edema and there's hemorrhage risk. And I will demonstrate. And on this slide, I've also included the link for the article. And also, as you see, Leqembi has the trade name. They have their own prescribing information details if you want to look at those. So this is just a demonstration of how ARIA looks. So on the left, you have the T2 flare axial sequence, and you can see this kind of increased signal. It has kind of a finger appearance like edema. There's a lot of swelling in this area. You see this white signal. So that's the ARIA E, or the edema that is amyloid related imaging abnormality that can be seen and that is not an insignificant risk with the treatment with these agents. And here on the right in the gradient echo imaging sequence, which is a sensitive sequence for hemosiderin or old blood products, you can see here these little micro hemorrhages. And these micro hemorrhages that we see that are the ARIA H, or the amyloid related imaging abnormality hemorrhage, look very similar to the microhemorrhages that we often see in cerebral amyloid angiopathy as well. Okay, so this is just to give us their hope that there's many drugs in development in terms of a variety of neuropsychiatric symptom treatment, disease modifying agents, cognitive enhancers, and so forth in the pipeline. Of these, most are really trying to target disease modification, of course, to try to find a way to cure the disease. And there are also ongoing efforts around treatments that address risk modification and risk reduction strategies. And those are really key components to our research and also to the care that we provide to people across the lifespan. So there are a number of trials, SMART and EXERT and US Pointer. And through US Pointer, which people are familiar with, the finger study, we've talked about that on a number of occasions. It's a multimodal intervention study which identifies folks at risk based on their cerebrovascular profile, actually, or cardiometabolic profile, I should say, and then enrolls them. And with a lot of lifestyle management and coaching, they found that these people over time had a lower risk of cognitive decline. They did better in terms of their executive function, and they've also done so many studies looking at less atrophy in the brain. I mean, just a number of factors demonstrating that this over 2 years, this multimodal approach can really have an impact. And these were people who did not have dementia at the initial enrollment. So we're now in US Pointer, we've enrolled almost 2,000 people. It's not as diverse as it ought to be. And there are a number of sub-studies looking at microbiome, looking at sleep, looking at imaging, and so forth. I don't want us to lose sight of the type of care that we provide, and really keeping in mind, and this article just came out about, exerkines and the role that they have to play in Alzheimer's disease. I'm not going to go into this now. And really thinking holistically about all these factors when we're caring for our patients, in a sort of age-friendly 5M approach we could map onto here as well, but really thinking about this as best we can holistically. So I'm going to kind of stop there. Whoops, and stop sharing. So I guess, you know, this has been approved. What I'll just add is that we have no idea at this juncture what insurance coverage there is. There have been 3 deaths that have been implicated or are found to be associated with the treatment that have been described in the literature. So we don't know the cost of the medicine. We don't know whether, as I say, insurance is going to cover it. And we know that in certain groups, I didn't actually talk about ApoE4, but we know also that people with ApoE4, whether heterozygote or homozygote, have an increased risk of the ARIA, the amyloid-related imaging abnormalities and those effects or side effects. So within that context, maybe we could open it up for conversation.
Yeah, I'll take a stab at it. You know, I'll say it's interesting to see the landscape shift a little bit. Most of you followed the aducanumab, you know, I will call it a debacle, because it really was, and it brought a lot of concern about the process by which the FDA approves drugs and the costs and the relationships, including the Alzheimer's Association relationship with the drug company. Like, that was really surprising to me, and a lot of like concern on the level of I would say a cautious family physician and geriatrician like myself, like, what are we doing here? And I think that, like, I've been following this story closely and noticing a bit of a shift. And the shift comes in a couple different ways. One is the outcomes were better in the lecanemab trials. The diversity within the trial was better, meaning more of our the patients that we take care of and that look like our patients were studied in this trial, and that there was, you know, there was measurable benefit, meaning less decline, and about what I heard of was like a third less decline over the 18 months, but not improvement, really important to note, not improvement in cognition and function, but decline. But they also measured things like caregiver burden through the Zuri burden interview, and that went down, which I thought was really meaningful to me. And my colleagues in like nationally in geriatrics, some leaders that I, you know, pay attention to, say that we should, and I don't know if you guys know the name Jason Karlowish. He wrote the book, The Problem of Alzheimer's. He says we should get on board because we need, that doesn't mean we give everybody the drug, but it means we need to understand that these drugs are here to stay. We need to be understanding of, like, you know, who are good candidates, right, for these interventions. We need to be able, and probably most importantly for this group, we need to really be able to identify MCI and early stage dementia expertly. So because that's the class of individuals that are eligible for this drug. And so that's like such a huge piece. And the complexities of real adverse effects, twice monthly infusions, quarterly MRIs, a ton of sources. I heard 25,000 a year-ish. So I think that's kind of the big picture with which the lens, I guess, with which I'm looking at this. And I think there's so many questions that remain unanswered.
Thanks, Carrie. That's really helpful. Yeah, a broader context. So anybody from the community have any questions or any thoughts about this? As you alluded to, I'll just add one thing, Carrie, that on this 18-point scale, the difference was 0.45 between the treatment group and the placebo group. And at 18 months, they didn't see a difference at 12 and they did at 18. And so there's been quite a lot written about whether this is clinically meaningful or not. And though, to your point, if there's less, our care partners are right alongside as well. So that's an important difference to note as well. Thank you.
I thought I'd jump off where Carrie maybe left off. I'm thinking about, primary care and the role of primary care here potentially, because these infusions, these probably will be done with subspecialty centers, and also, this when to make the diagnosis of with an amyloid biomarker, how that is done will probably be through a subspecialty center. But I think a lot of people will be turning to their trusted primary care provider to say, is this the right next step and what to expect? So I think this counseling of this is not a cure, unfortunately. All of those graphs, unfortunately, there will still be a continued decline, hopefully slowed, but putting the perspective of we are not looking for improvement, stabilization, that unfortunately this will not be a turnaround drug. Also, that as time goes on, Carrie, you mentioned that quarterly MRIs, it is going to be so important, that follow-up care given safety concerns, and emphasizing the imaging needs to happen, it can't be skipped. And then the other side of, we don't know how long this treatment should last for. And there may come a time when it may be better to stop these infusions, and how to navigate that. And again, so seeing that being a multidisciplinary discussion that I think general practitioners will be brought into by patients and families.
Thank you, Kimmy. And also, what if your patient develops atrial fibrillation and needs to be on anticoagulation? I mean, all of these complex questions around multimorbidity, which most of our patients have more than one thing going on at once, developing new challenges. And
that's Nancy, yeah, and I had heard that, of the 3 deaths, one of the persons was on, I believe it was clopidogrel. I think it was an antiplatelet agent, and one of them had a stroke and had gotten TPA, and I guess there's a likelihood, right, that it was really the highly complex nature of the medical illness that led to the death and not the drug. But it also will likely mean that we will probably exclude some folks, or suggest some groups of folks not be a good candidate for this medication if they have, some of that complexity.
I'm curious, from our community, do you think that, do you use visual teaching tools for shared decision-making in your office? Number one. And number two, even if you don't, do you think something like that to talk about this might be helpful?
Hi, Nancy, this is Jeff. I do use some visual tools and find that using absolute risk reduction really helps patients with the decision making much more than relative risk reduction. And I guess if I asked oriented evidence that matters, and I look at this, I have not read the article, but I'm having trouble realizing whether this really made a significant difference in people's lives. Carrie mentioned caregiver burden, which was also mentioned with memantine, although they never showed what that caregiver burden was or in what way it changed. And so what did families really find with this? Did they think that the quality of life was better, that people were able to stay more independent? Because to me, that becomes the focus of the discussion.
It's such a good question. And I think that they did the like Zaret burden scale. And so, that's just one way to measure this. This is my take on it. My take is like, it's called moderate improvement in the article. It's pretty minimal impact on daily life, but, and I heard statisticians say a delay of of this phase of dementia 4 to 6 months. That's how the data was interpreted, at least by some group of statisticians. And even though to me and you, that may, because the benefit is so it probably difficult to see clinically, it may not be worth it. There's a whole bunch of patients, individuals, and families that think it is worth it. And so that's where, like, I think the distinction comes. There's going to be a whole lot of people that don't think it's worth it, but anything to slow the progression, I think, is the cry from a lot of individuals and families. And our perspective, or my perspective, has always been like, is this worth it? This seems so tiny. Like, is this worth it? And so that's where, like, I am trying to keep my mind open on the intervention for that reason.
I might be playing devil's advocate, Carrie. I sat on Kaiser's P&T committee, and we had this discussion about a chemo drug once, and it provided maybe about 24 days of extra life, delayed timing, but a lot of adverse effects. And the question came up, do we approve this? And one person said, if it were my money, there's no way I'm going to spend my money. But if it's somebody else's money, I'm happy to have it. And that becomes part of the crux, because I think you have the pharmaceutical cost, but also the total cost. And then you have the stewardship argument. I'm not denying what you say at all. I think this is going to be incredibly, I already have a person who's a health professional who is asking about this for his spouse. And frankly, I mean, I don't know how we're going to approach this, because it's going to be, I think, very difficult questions for just the reasons you're mentioning.
I would say that I really like Carrie's comment about getting on board, because I do think that there is, while a lot of apprehension and concern and a lot of questions, I think that there's a lot of promise when there's a vision of the future, that there might be treatments rather than just palliative management of dementia. So I'm really but I think it seems like this is just a very, very, very early step towards that, and so many questions about logistically that I don't think that, yes, in primary care, I could even imagine the logistics of a patient ask me currently for it, except to say that there is, and the biomarkers, I mean, just getting the definitive diagnosis, I think is probably the first thing for me to know as a primary care of like how to get someone more validated on their diagnosis of MCI. I think that's probably where I'd want to investigate more first.
And I'm curious, Nancy, and then those at Kimmy, like Swedish and UW, like what are they saying? Like, what are they saying? How am I going to get either my CSF or my amyloid PET? Like, how are we going to do that?
You're not going to get your amyloid PET, as I made
So this is going to be CSF?
As I hope very clear, because it is not it's not approved for clinical use. So you will not, unless you're participating in a clinical research study, have the diagnosis made based on amyloid PET. The diagnosis, unless you had participated in some prior research for whatever reason. So Medicare, it's not supported by insurance. So lumbar puncture for CSF biomarker determination of Alzheimer's disease is what's going to happen here and elsewhere.
Yeah, it is. I mean, somebody could pay out of pocket for an amyloid PET scan because it actually, the tracers are FDA approved. But it is quite costly. But certainly, if somebody is entertaining the idea of embarking on treatments like this, they've already been thinking about cost. And then the other sort of subtleties of when to pursue the spinal tap. It has to be collected in a specific tube. You have to be careful about the tubing because you even to collect it, you can sort of get false positive readings. So there are some caveats there in making sure that the test itself is performed appropriately. There's also just one more about thinking about also the timing of that. There are other things that can affect, especially if you're looking at tau in the cerebrospinal fluid. So if somebody recently, for example, had a seizure or a stroke, that may not be the time. You might want to wait several months before pursuing a diagnostic spinal tap because that can affect the tau numbers, and sometimes that is incorporated into the interpretation of the cerebrospinal fluid results.
Which would, that just knowing that the first step, knowing which is a candidate, is probably the most important. I think when you say that the tau would be affected by a recent stroke, you're also thinking, well, that patient will likely be on antiplatelet, and then it almost seems like if there was a consensus across the board that an antiplatelet was just too high risk, that would be an easy way to kind of say very early on in a discussion, this is not the right medication for you. What level of MCI would further, I'm thinking like of patient examples. I'm thinking of an engineer who is where his cognition is very, very important to him, has a few marks down on his, MOCA, and is he or she a candidate for further testing, like a referral to Swedish? It's hard to know.
No, thank you, Julie, for really articulating so well the quandary that we are facing, that primary care, that people who know their patients best and who of course want to help them in any way that they can, that is safe and clinically effective, clinically meaningful and safe, and I would say from a population level, ideally affordable. Of course, thank you for voicing these challenges, because it's super complicated. And I think for that individual, that's a great example of somebody for whom it might be worth at least further discussion and that referral based on what you've described. He's an engineer. I'm hearing that he's valuing his independence and his thinking, and he has mild cognitive impairment. So that perhaps is somebody who you would have a conversation with regarding this and pursuing a further diagnostic workup. I think in the service of our case, I'm going to have to leave it there. I know we could go on and on, but I
want to say one more thing, just
please.
if it's okay. It's okay.
Yeah, of course.
Only because this is going to be a practice changer for me, because when I sit with a patient, and all the time I do with this MCI early dementia diagnosis, I say, like, what I say to the residents is, and the fellows, this is a marathon, not a sprint. Like, this is monitor over time, create the support, work on all of the other things we know impact people's lives when living with dementia and can prevent progression. Now it's going to push us to take more action earlier. And that's a really interesting place to be.
Thank you. Thank you.
Hi, this is Karen. Can I just say one thing as a caregiver?
Yes, sure.
Yeah, sorry, I'm in my car if I can't hear me very well. I'd say, you know, when my husband got MCI, he was not on Medicare yet. He was too young. He was not getting Social Security. He had to quit his medical practice early. And we have a finite pot of money. We had a high deductible, off the shelf, pre-Obamacare health insurance. And now 9 years later, I'm getting ready to put him in a memory care place, which is going to be starting at $10,000 a month. And I think the marathon thing is important because you got to talk to your patients about where future money is going to come from. Because if we'd spent all our money on this to delay MCI to moderate dementia by 4 months, I would have nothing to put him into a care facility, and I can't take care of him anymore. I'm completely hollowed out. And if I had to keep him at home one more month, much less 3 or 4 more years, I don't know what I would do. Because the support just frankly isn't out there. The home caregivers, the friends, family, it fades away the harder they get to take care of. So if I was counseling somebody, I would really want to, and a lot of people don't want to think about the future, but now that I'm here and living the future, it's like, oh God, you got to think about the future, and the finances are critical. Not to mention, as the caregiver, you can't go to work when you're driving them to we want to get them off the roads, right? But the caregiver's got to drive them to the appointments and the MRIs and to the hospital for the complications, et cetera, et cetera. So I think it's a bigger systems conversation within a family, mapping it out to see, is this where we want to put these eggs? Maybe so, maybe you've got resources, but if not, you need to conserve your resources for when things get really, really hard.
Mhm.
So that's what I wanted to say about
Well,
this.
thank you so much for really underscoring the importance of thinking about this, as you say, in a marathon context, conserving resources. We unfortunately in the States have far too few resources to support people living with dementia and their families in communities, and we need to do a better job there advocating as well, but to really think along that big picture of the natural history of what can happen over time. So thank you, Karen. That's so important for us as people who are trying to serve you best to really retain awareness around. It's really critical. So thank you for speaking to that as well. So now shifting gears a bit, Elizabeth Horton is from a Virginia Mason Franciscan Palliative Care Outreach, is here to present a case, and I'll just drive. Ready, Elizabeth?
Yes, hello. I look like I'm wearing the same shirt as I am in the picture.
Oh, Libby, sorry, Libby. Thank
Oh,
you.
that's okay. I'm Elizabeth everywhere, but I go by Libby. People are like, what's your name? And I show them my badge and it's Elizabeth. So, well, thank you for letting me present this case today. I'm looking forward to what other people have to say, because this is somebody that I don't typically see and was very, I'm up at night thinking about her. So anyways, I work in palliative care. So this is a patient who I've seen once so far and was referred to me from her primary care provider for a palliative care outreach consultation for symptom management and goals of care. So she is a 75-year-old female with a history of TBI, hepatic encephalopathy, liver transplant, who was referred to me. And also, just to note, her family is anxiously awaiting a new appointment with UW Memory and Brain Wellness Center at the end of May. So I'm wondering if I might have some things to bring to them from you today. So she had a ground level fall on June 3rd, where she was found to have a subdural hematoma that didn't require operative management. And she was in the hospital for 10 days and then discharged to a skilled nursing facility. But soon after, on the 6th of July, she was admitted back to the hospital with hepatic encephalopathy, hyperammonemia, UTI, and a PEG tube malfunction. She was in the hospital this time for 45 days until August 20th. And at that point, she was discharged back to a skilled nursing facility and finally back home in the middle of September. So before this all happened, she was independent, living at home with her husband, no history of behaviors or dementia, anything like that. So when she discharged home in September, she was home with physical therapy, occupational therapy, speech, nursing. Those are all still in place because she is still showing improvement. Once was bedbound, now able to get up with assistance to use the commode or sit up in a chair. And luckily she is able to eat by mouth now because last week she pulled out her PEG tube and they were unable to get it back in. So she has maintained her weight with oral intake. And her husband has been able to get her to take her medications orally, albeit difficult. So some previous history on her that just adds to the interest of the case. And she, in 1995, was diagnosed with liver failure. The family told me it was from a side effect of Zoloft. So she had a liver transplant. And when she was in the hospital, the family explained that she was in a wing with several other immunocompromised people that was under construction in the hospital, and several people developed aspergillosis. She developed blindness to her left eye, but to date, no lasting respiratory symptoms that I'm aware of. So on the next slide, this is her medical history. She has, I mentioned this earlier, but she has maintained her weight. And her labs have been within normal limits recently. Her ammonia levels, she's taking her lactulose pretty well. And she does follow with UW hepatology for her liver. We can move on. And so she's living at home with her husband, who is a 24-hour caregiver, who is just about at his wit's end. She does have 2 daughters who do live close by, but are full-time workers and, provide support when they can, but it's mostly the husband and plus a few hours of caregiving each week. But she is, needs 24-hour care. So now we move on to her behaviors. When I met her 2 weeks ago, I hadn't seen anywhere in the chart about behaviors or memory loss or anything like that. So I met her and it was just instantly, she can't answer my questions. Anytime I ask her a question, turns it back on her husband about something that she saw earlier in the day and is really angry about. She has hallucinations of robbers and thieves robbing her in her home. So distressing to her. And it's even worse because her family tried to say, nobody's here, you're okay. And she then blames them for not believing her. And it happens frequently and it's a bad cycle for them. Anyways, just more behaviors, but it's not looking so great. So we, our palliative care outreach team, consult with Dr. Warnell, geropsychiatrist, for, I consulted with him last week after this appointment. And we were talking about, he was thinking that there potentially before this hospitalization, she maybe had some cognitive impairment, maybe not, family couldn't notice it. But the hospitalization and everything she has gone through could have really exacerbated the dementia. And now we're seeing dementia with psychosis. So his recommendation was risperidone, 0.25 milligrams twice a day. Being high potency, we would see results quicker, potentially less side effects. I wish she had started it already, but because the husband has a really hard time getting out of the house, they're waiting for it to be mailed to their home. So it's supposed to be coming today. So really good timing. But I guess they haven't started it yet. So if anybody else has other recommendations or ideas. So I had consulted with her primary care provider. We're consulting providers, so we don't prescribe. So her primary care is the one who is prescribing their risperidone. This was a CT from November, just that showing there was no acute intracranial pathology left over, I think, from her TBI. Her levels, her ammonia levels were within normal. And then her medications. And so her goals of care are, haven't discussed this with them. This is just from very brief. She had a pulse form. We brought it out and I tried to ask a couple questions, but it wasn't a good idea. But her current pulse form is DNR comfort. So my main question, I guess, is, yeah, like just her significant behaviors that are going to make it so her husband's no longer going to be able to care for her at home because he can't manage it. And they, try behavioral modifications. She has a counselor that comes to the house. She doesn't have pain. She isn't constipated. We tried to work through a lot of those things too. So I guess my question is, what do you think?
Thank you, Libby, for that very, very complicated patient presentation. And it sounds like her main issues are sort of her behavioral challenges now. And so do people have any questions additionally for Libby?
Also, something I wanted to share that I forgot.
Sure.
It's just another interesting thing to this case. Several years ago, her spouse's father, so unrelated to her, had a fall, subdural hematoma, developed dementia with really bad behaviors in memory care. I mean, he passed away. So I just thought that was so fascinating that this is the second time that family has gone through this.
Yeah, you could imagine that that's bringing back those experiences and memories. Yes. So does anybody have any additional questions for Libby? Thanks for that great presentation. Really terrific.
Did you mention mood disorders and like in her history and whether she, just thinking SSRI as like often a first line, not necessarily for severe symptoms, but I may have missed that.
No, that's okay. She did have a history of depression. Zoloft was what triggered her into liver failure. So she is on mirtazapine now, but that's also for her appetite. So mirtazapine a little bit right now, but nothing really for mood.
Hi, this is Kimmy. Yeah, great presentation. Lots to mull over. You had mentioned that she lost vision in one eye a while ago. Do you have the sense, how is her vision now in the one remaining eye?
That's a really good question. And they, it is impaired. So I think that leads to more, because it leads to a lot of distrust, she says, and her family says, like, well, I can't see the medications, or I can't read the medications, or I can't see. So it does, I think, add to her behaviors not being able to see. And they try to, like they really try to put things in her field of vision that she can see. But maybe we all think risperidone was the right move.
Is she already on memantine or donepezil?
Has never been.
Okay, because maybe adding memantine to help with some of the behavioral symptoms can help too. I don't know exactly what the dose adjustment would be with liver cirrhosis, but you could consider adding that. And then what dose of mirtazapine was she on?
15.
Okay, because you could increase that to 30 or 45 to help more with mood symptoms.
That's true.
Thanks, Emma.
Yeah, thank you.
Great. Any other thoughts from our community?
This is Karen. I can't speak to the medical care of the patient, but I'd like to speak to the current situation of the caregiver, who I think was, and just wondering what resources could be mobilized for him, because no matter how you treat the patient, if he keels over or has his own psychotic episode because he's just exhausted and at his wit's end. And just so you all know, and I'm in a Facebook group for my husband's type of dementia and so forth. There's a lot of suicide, homicide talk amongst caregivers because they don't know what else to do. So I'm just thinking one way to support her is to support him. And if there's some way to get neighbors to come forward, or if they're in if they have a religious affiliation and some kind of resources there, or just any kind of free, or I don't know what the resources are, but any kind of in-home respite care for him, just to get out so he can take care of himself and or get a night's sleep. There's also some good books out there on how to manage behavior. My husband happens to have Lewy body. There's a really good book by the Whitworths about how to manage hallucinations and so forth without drugs, which don't always work or don't always work the way you want them to. They can have paradoxical reactions sometimes. But just, yeah, I just think gathering around the husband to support him so he can support her is going to be critical for this person to be able to remain at home if that's their goal, or if not, to make the transition into memory care or nursing home.
Thank you, Karen. You bring up a lot of good points, and I did give him some resources like the Alzheimer's Association for support groups and some pamphlets I have on caregiving, but respite care is an interesting one. I know like how that can work on hospice, but before hospice, sometimes I have patients that are looking for respite care, whether that's like a 5-day stay at a skilled nursing facility. And it's always been really challenging for them. And I guess I'm curious if anybody has a magic wand.
I just say people are given resources, and if you're somebody like me who's a go-getter, and I'm a nurse, and my name's Karen, I could be kind of assertive with people. That's fine, but I'd say the majority, maybe 80%, military wives or other people who get things done. But the majority of people, they can't pick up the phone. They're either depressed or overwhelmed, or they've been down the road and making a couple calls and nothing came from it. And so I think sitting in the clinical setting with a social worker or a nurse, actually dialing the number and saying, let me help you make this phone call, and then helping them talk to whatever the resource is. Because you get home and you just put that stuff in a corner and you don't look at it again, because the caregiving is just in your face 24/7, and you don't have the bandwidth or the what should I say, the self-preservation instinct to make the call even out of desperation. So hand holding them through finding resources, I think is critical.
Mm-hmm.
Thank you, Karen.
Yeah.
Yeah, and if the care partner, as you say, doesn't have that community of support or access to those resources, then the care isn't possible. It's just really insurmountable. So really making sure at each visit, and as best we can, to bring that support and connect, maybe, as you say, sitting with the person, really sitting elbow to elbow.
I'm going over there this afternoon, so we're gonna look through what I sent him last time, because that's, yeah, I just sent him. So think that'll be good to look through together and see what he thinks could be helpful for him.
And Lynn, I see you popped in the chat, and then I also popped in the chat this psychoeducation, tip sheet for family and care partners. Did you want to unmute yourself and share?
Yeah, I'd be happy to share. The one thing I would suggest, Libby, they were in King County, right? Are they in the King County area?
Yes, King County.
Yeah. Okay, because I popped in the chat, the AAA, the Aging and Disability Network, and you probably know about those services. But one of the things King County does, they're one of 7 AAAs across the state that has Star C consultation, and that's an evidence-based consultation sort of dementia education program. It was developed by UW School of Nursing, Linda Terry and Rebecca Logston years ago. And it's an in-home consultation program where they actually work with the caregiver to identify things that are bothering them on the behavioral scale, and then work with them sort of on a homework basis to try new things. And very often, you're literally just looking at the sort of ABC approach, the behaviors and the activators and the consequences, and focusing on the things that are really stressing the caregiver out. And, the good thing about that is that it's little blips of information. It's not just, a sort of one-time education, and you go back with the family caregiver. And specifically because you said there are the daughters involved, you can even involve the daughters if you wanted. And, the example you gave about the eye thing was like a perfect example, because you could think of ways to sort of work around that and problem solve around that so that they don't have that stress related to that specific behavior. So it's really tailored individually to what the caregiver is going through and the things that bother them the most. And I think that can really be helpful. So anyway, I put the name in the chat for you if you want to ask about that.
Wow, thank you. I have not heard of that.
Yeah, and King County actually has 2 trained, very experienced Star C consultation folks. So that could be useful.
Thank you.
Thank you, Lynn. Super helpful. Trang, is there anything you'd like to add? You're muted. We can't hear you.
Okay, hi, can you hear me now?
Yes.
Okay, great, thank you. Great case, Libby. I do have a question. Did you say that her transplanted liver is now having cirrhosis?
Mm-hmm.
Okay. And then also the family mentioned that Zoloft caused the liver failure. Do you know if the patient already had liver issues before that?
Not to my knowledge.
Okay, she's also on thiamine. Do you know if she has history of alcohol abuse or alcohol use?
That's a good question. I don't. Not currently, but in her previous history, I'm not sure.
Okay. Yeah, this is something I was wondering that, Zoloft is very, I'm seeing it, but I know that it has to be used very cautiously in patients with liver disease, and not to exceed 100 milligrams of Zoloft per day. That was something that I had in mind. Did the patient have underlying liver disease before starting Zoloft? And then now the patient has a liver transplant, and the patient has cirrhosis again. So what's the reason for that? And I just see thiamine B12 on the med list, and I was wondering if patient has had alcohol use and is still having alcohol use. So it might be something that we can discuss, and you might want to bring it up and ask the patient.
Not currently, but I don't know how recently. I guess I only asked if she was currently drinking alcohol, and she's not. So that's a really good point. I don't know what her history previously was.
Thank you, Trang. And then there's a question in the chat that Barbara's asking about memantine and the increased risk for hallucinations in the setting of paranoia with poor vision. Sorry, Barbara, were you? And, you know, that's an empiric question, certainly, meaning that it's not the first thing that I would go to here if there's a lot of agitation and combativeness. I mean, I think you can consider adding that on, but if her agitation and combativeness and her psychotic behavior is really disruptive to her and the family, which it sounds like based on your presentation, then it is, then, you know, while it is true that we want to try to avoid those antipsychotics, that high potency one might really help with the symptoms and really ease her suffering and the suffering of those around her. In terms of the utility of memantine, you know, the NMDA antagonist, it can help with these neuropsychiatric behaviors. So it's really, and have I seen people become more agitated when initiating a trial of memantine? Yes. Have I seen it maybe help in the long run? It's hard to say. So I don't know, Trang, if you would wanted to add anything to that regarding the question of memantine.
I'm sorry, can you?
Oh, that's okay. Well, that's all right. So just because there was a question in the chat about if memantine may possibly increase hallucinations in this setting with poor vision. It's not a common side effect.
No, it's not.
In my opinion, from my experience, it's not very common. No worries, Barbara, thank you. And then Carrie, do you want to unmute yourself and pose that?
Just a bit of a broken record, because I often bring it up because I'm curious about what we'll see in terms of data later on. But prazosin is pretty well tolerated, especially at low doses. And there's a little bit of evidence from some time ago of utility in the like hypervigilant symptoms that come with behavioral changes in dementia. And Kimmy, I don't know if you know any updates on what they're doing in terms of studying it at UW, or anybody else has heard whether.
Yeah, I don't think there's been any further updates, but I think it's definitely a good option to consider. And I guess, Louis, have you also had a chance to screen for Lewy body disease? I don't know if you can check her tone, especially before she starts risperidone.
I haven't, and I wouldn't. I'm not familiar.
Kimmy, that's a wonderful point. Can you just elaborate that for the community and really underscore the importance here? Thank you.
Yeah, and Karen may have some thoughts here too. So yes, you know, when we think sort of when we hear, especially, you know, confirming actual hallucinations and then the delusions as well early on, makes us worry about the possibility of Lewy body disease, and then that, you know, just the increased sensitivity to medications, increased risk of neuroleptic malignant syndrome, and then especially if the behavioral symptoms are to the point where we're thinking about medications, really being cautious with behavioral issues. Sometimes, you know, Haldol can be reached for, and that would be contraindicated. And so this opportunity to see if there's the cogwheeling that you might think of with Lewy body, it could be important to screen for.
Yeah, this is Karen, super important, because all of a sudden the things you put on the allergy list are extensive because they can really mess up their brains if they're given the wrong medication. So that's my understanding anyway. So finding out if Lewy body is part of this, I think would be helpful so nobody regrets making a medication error.
Absolutely.
Thank you. Trang.
Sorry, earlier I had unstable connection. So then I have to drop off and jump back in so I can see the question. So to answer Barbara's question about memantine, it can increase the side effect in the setting. I think anytime people have issue with sight vision, I think it's important to take that note too, because patient would be confused and they even without the medication. But in regard to Namenda, the side effects is for hallucination is about less than 3%. I just looked that up. So it's not common, it's less. But with the OID vision problem, just know that the side effect is not rare, but it's small. But it's something that, like any other medications, when we start the medications, we just have to monitor to see if it's actually helping the patient or not. But also a lot of SSRI, like Carrie mentioned earlier, can be used as well before using antipsychotics, like Kimi said, to screen out for Lewy body. So there's a lot of SSRI that can be used in liver impairment. Another option if you have to do that.
Excuse me, this is Chris. There's also a really excellent question about the safety with cirrhosis about raising the mirtazapine dose. I don't know if you have thoughts about that, Trang.
Mirtazapine. I think currently there's no dose reduction. Some expert no dose reduction recommended by the manufacturer, but some experts recommended reducing the initial dose by 50% with a maximum dose of 30 milligrams in patients with hepatic impairment. And that's the hepatic dose recommendation. And I usually also go to side effects. It increased the liver test about more than 3 times, but that only occurs 2%. So about 2% of the time that mirtazapine can increase the serum albumin, the AST more than 3 times. But that only occurs about 2%. So that's a risk of increasing the liver enzyme, about 2%. But hepatic dose can be used up to 30 milligrams a day. I hope I answered your question. Is that correct?
Thank you. Thank you, Trang. So we're at 1:30. So being respectful of your time, I think you can see that next on February 10th, Dr. Sumi Jayadev is going to talk about, actually, this is wrong. Sorry, it's Dr. Brock Gaster who's going to talk about primary cognition and primary care. So I'm going to stop the share and just say that. And we hope to see you in a couple of weeks. And thank you all. Thank you, especially Libby, for your wonderful presentation of this really challenging situation, and also for everybody who contributed in the community.